as we share our research on outcomes following surgery for breast cancer. So my name is Alice and I'm a junior doctor and I'm also a researcher at Imperial College London. So first of all, I'll just introduce the topic of therapeutic mammoplasty because both myself and Yasmin will be talking about this. So some of you may already know about this, perhaps others of you won't. So it's essentially a procedure to remove cancer, and that's where the therapeutic part of the name comes from. And it also involves reshaping the breast by removing skin and breast tissue, or perhaps rearranging it. And that's where the mammoplasty part of the name comes from. Sometimes it can also involve surgery to the unaffected breast, so the breast without the tumor, and that's to improve the symmetry. So in the image on the slide, you can see the blue lines represent different scar patterns that you can get with therapeutic mammoplasty. So what are the alternatives? Well, some older techniques are mastectomy and lumpectomy. And therapeutic mammoplasty is really increasing in use across breast units in the UK. And studies have shown that it's as oncologically safe as these other forms of breast surgery in certain patient groups, which means it's as effective as removing the cancer. Okay. So if it's non-inferior to the other techniques, and you may be wondering, well, then why? And there are a few reasons really, and it's quite patient specific. So for example, in women with large tumors in small breasts, therapeutic mammoplasty can be used to avoid mastectomy, which is a bigger operation and can involve further procedures down the line for reconstruction. It also has a better cosmetic appearance for larger tumors than lumpectomy, which can cause quite a significant defect in the breast. And it can also improve symptoms associated with large breasts, such as back pain. So if that's something that a woman has struggled with pre-operatively, then therapeutic mammoplasty might be something that they can consider if it was a suitable procedure for them. So my research is really looking at outcomes in therapeutic mammoplasty. And when I say outcomes, that's really a good definition of that would be a way of measuring how successful a procedure is. And that can be measured in many different ways. So for example, has the cancer been completely removed? A woman's appearance and her quality of life after the operation. And so the question we're really asking is if therapeutic mammoplasty is as safe as mastectomy or lumpectomy, then really we need to have good evidence for its other benefits. So its benefits on appearance and quality of life and functionality and also cost effectiveness, which my colleague Yasmin will be talking about a bit later. And so my specific project is looking at which outcomes are most important to patients and healthcare professionals after therapeutic mammoplasty. And that includes how they should be measured and when. And this is a really important question because when we're looking at how effective a procedure is, what we really need to do is compare across lots of different studies, all of the data and the evidence that we have. And a prerequisite of that is making sure that everything is reported in quite a standard fashion. So identifying which outcomes are the most important and then putting them into a course set helps to standardize all of the research across the field. And so my project is in 3 stages. First of all, I'm going to do a review of all of the papers that have been published on this topic. And that's really asking the question, which outcomes do researchers measure? But obviously, researchers aren't the only important people to answer this question, and we have to speak to patients as well. And so that's the second stage of this project, which is patient focus groups and interviews. And that will help us to answer the question, which outcomes are important to patients? And then in the 3rd stage, we'll be doing a national survey, and that will include surgeons, breast cancer nurses, and patients. And that will help us to rank which outcomes are the most important out of them all, and whittle them down into perhaps a top 10 or a top 5. And that will help to standardize how we report outcomes across the field. So I can report some preliminary findings of my review. So many of the studies that I looked at survival and recurrence, but most had fairly short follow-up times of less than 5 years. So that's an improvement for future studies to work on. Interestingly, only half of them looked at the aesthetic outcome, so the appearance of the breasts after the operation, even though that's really one of the driving forces behind doing therapeutic mammoplasty. And those that did look at appearance used subjective and non-validated tools to measure it. Oftentimes, the timing of that assessment wasn't reported as well, and that's really important because the time since the operation and whether or not the patient has had radiotherapy can really affect appearance. Also, none of the studies reported baseline satisfaction with appearance. And again, that's really important because if a woman has, at a baseline dissatisfaction with the appearance of her breasts or the size of them, that will impact how they rate their appearance after the operation. And it's also another driving force behind choosing this procedure, amongst other factors. And lastly, very few studies reported quality of life, function, or cost effectiveness outcomes, which we know are very important. So in terms of the next steps, I think we clearly need further evidence. So we need longer studies of longer duration, and we need much better data on aesthetic outcome using validated and patient-reported tools. So a third of the studies that I looked at, actually, the aesthetic outcome was only rated by the clinician or the surgeon and not the patient. So we clearly need to involve patients much more in how we assess the outcomes of this surgery. It's really important to state the timing and also to understand the baseline satisfaction with appearance and quality of life. And we need much more data on things like quality of life, function, and cost effectiveness. And as I mentioned before, patient input will be absolutely essential in this process. So that's the end of my talk. Thank you very much for listening. I'm going to hand over now to my colleague Yasmin, who is going to talk to you a little bit more about cost effectiveness.
Thank you, Alice. So my name is Yasmin. I'm a registrar in breast surgery with Mr. Laff at the moment, and I'm also a research fellow at Imperial. And I have undertaken a study looking at the cost effectiveness of this procedure, which Alice has described in beautiful detail, called therapeutic mammoplasty. And essentially, the aim of our project, the background to it, is that ladies cannot have a therapeutic mammoplasty to excise their tumour and also to combine breast reduction and lift techniques. But the opposite breast may be left lopsided following this procedure. And having a downstream balancing operation can result in delays and can impact quality of life and body image. And our solution has been to offer an immediate balancing procedure on the side that's not affected by the cancer using a two-surgeon approach. Mr. Leff works in close collaboration with one of his colleagues, and we hypothesized that this is associated, if you go back one slide, Alice, this is associated or may be associated with better body image because ladies are not left lopsided for significant periods of time. May also be associated with better intraoperative decision making because there are two consultant colleagues working together on each side of the breast. May have opportunities for trainees like myself and my colleagues on the call today because we have supervision by two consultant surgeons. And it may also reduce unnecessary hospital episodes associated with a second operation, and that also may reduce contact points for COVID-19 exposure. And also there may be a costing element to this, so we assumed that having an immediate balancing procedure would reduce cost to the hospital and may also reduce indirect costs to patients, such as time off work time off work and self-isolation in the COVID era. So I have conducted a study looking at the records over a 5-year period at Charing Cross Breast Unit and taking the costing episodes from a software package that is available in the NHS, and it's called Patient Level Information and Costing Systems. And it gives a granular, detailed cost result for every patient's clinical episode. So every time a patient steps foot into the hospital, this software gives us detailed costs about what that episode has accrued. Thanks, Alice. Next slide. And so from this result, this graph, we can see that the results are, they show, if you look in on the left-hand side, there's a significantly increased cost associated with having a two-staged approach. So having an initial cancer operation followed by a balancing procedure later down the line, say a year down the line after completing radiotherapy to the breast. If we do the procedure up front on both sides, this is associated with a much reduced cost. And if we do one side alone, but leaving patients potentially asymmetric or lopsided, that's associated with a lower cost, but then there may be quality of life issues associated with that. Go to the next slide, thank you.
Oh. 1 second, oh, there we go.
And the red lines on those graphs, they indicate that they're statistically significant when we test them in statistical programs. And just to reiterate, so a staged procedure, so two procedure in a staged approach is an additional £3,909 more than having both breasts operated on at the same time. And that makes sense because you would assume that having a second general anesthetic, a second hospital visit, the second hospital clinic outpatient appointments, that would result in higher costs. And the cost of second surgery was just over £2,500, and that represents quite an additional cost burden to the hospital. And obviously, we're very keen to understand how this also affects patients by being lopsided for a protracted period of time. One of the financial business partners at the trust conducted something called a sensitivity analysis, and it looked at the fact that we could achieve a move to doing 50% immediate both-sided surgeries with an improvement in our income to the hospital that we receive from the NHS of over £250,000 per year. And that this could be achieved without hiring additional surgeons, and it could also be achieved by with reducing theatre hours and theatre time. So we suggest that doing both breasts at the same time is associated with better health-related quality of life for women affected with breast cancer, but we need studies such as Alice's to look at that further. And we've shown here that doing this approach with two surgeons operating at the same time in the same episode is associated with a significant financial benefit to the NHS and to society as a whole. Next slide. We've also shown that it's safe. We had no increased rates of complication in our immediate both-sided approach. And we feel that surgeons collaborating in this way may reduce waiting list times, which obviously are at an all-time high following the pandemic. But we need future work to involve what patients think and how it affects patients, and also to assess what the cost is nationally in other breast units. Thank you very much.
Thank you, Yasmin. So I'm going to take over. I'm just going to share my screen now. Can you see my screen?
Yes.
So hello everyone, my name is Amelina, and I'll be presenting the bracelet study today. So it is objective assessment of post-op morbidity or complications after breast cancer treatments with wearable activity monitors. So breast cancer is the most commonly diagnosed cancer worldwide, and since 1970s, the breast cancer mortality rates have reduced by about 40%. And with breast cancer survival increasing due to advances in screening, diagnosis, and treatment, greater emphasis is being placed on addressing the complications and long-term effects of treatment. There are long-term complications associated with breast cancer treatments, such as pain, lymphedema, swelling, and also reduced range of motion. And all of which can affect patients' daily activities and reduce their quality of life. So breast cancer patients receive multiple modalities of treatment, such as breast and axillary surgery, radiotherapy, hormone therapy, chemotherapy, and breast reconstruction surgery. And these are determined by their stage, grade, receptor status, histology, and also patient's preferences. So the current validated tools to measure upper limb dysfunction are mainly subjective, such as the DASH questionnaire, which is a patient-reported outcome questionnaire, and they rely heavily on recalls and patient's compliance. There are also objective measures such as sternometry to measure range of motion, and whilst these methods may be useful, they may not reliably capture the functional morbidity and complications of breast cancer treatments and provide poor comparison between patients. So we use wearable activity monitors, or WAMs, which have the potential to capture a more reliable and continuous objective measure of physical function, which might help to better delineate the recovery process. So we would like to assess the feasibility of using WAMs to measure the arm functional recovery after breast cancer treatments. And so it's basically it's called activity triaxial accelerometers, which measure the upper limb activities in 3 planes. And WAMs have previously been used to assess activities of the arm in stroke patients, Parkinson's disease, and patients with broken bones in previous studies. So it is a single center study conducted at Imperial College Healthcare Trust, and patients undergoing breast surgery were identified from theatre lists and also our meetings, and patients with movement disorder or using mobility device or aids or unable to provide informed consent were excluded from the study. And so patients were asked to complete the questionnaires before and after surgery and asked to wear the WAMs at least 48 hours before surgery and up to 2 weeks after surgery. And then the data was collated and analyzed in our software to find out the statistical comparison between the different types of surgeries. So this is the results of my feasibility study. So I'm not going to go into too much detail, but essentially when we calibrated the activity levels to the pre-op activity levels, you can see here that the arm activity dropped post-operatively from about 100% to 45%. And you can see that the regain of function was gradually observed on the operated side of the arm through the increase of physical activity as a percentage of pre-op levels during the post-operative period, with the greatest increase between day 1 and 2, with the recovery plateau around day 7. And greater activity was observed in the control side compared to the operated side, with a significant difference in week 1 and 2. And when we're comparing the different types of surgeries on the armpit, so sentinel lymph node biopsy is when you remove a few samples of the lymph nodes from the armpit, and axillary node clearance is when you remove as many lymph nodes as possible from the armpits to do a clearance of the lymph nodes. So it's more invasive than sentinel node biopsy. So when you compare between these different types of surgeries, patients receiving axillary node clearance demonstrated a lower physical activity level compared to sentinel node biopsy patients after week 1 and week 2. So as a summary, the results highlight a decline in arm function on the operative side and a gradual recovery which does not return to baseline even at 2 weeks after surgery, and non-operative side remain more active than the operative side throughout the 2-week post-operative period. And axillary nerve clearance patients, which is more invasive surgery, showed lower post-operative activity levels compared to sentinel node biopsy patients. And so this study demonstrates the feasibility and validity of WAMs towards objective monitoring of arm recovery after breast and axillary surgery. In terms of future work, we would like to develop a scoring system combining objective measure and patient-reported outcome measure, for example, pain, in order for us to assess functional outcomes. And also would like to expand recruitment to compare different types of breast cancer treatments and follow up at different time periods. Particularly, we would like to quantify the complications of different treatments, which may help the clinician and also patient to choose the most suitable modality, particularly where the oncological outcomes are atypical in breast cancer surgery. We also would like to measure level of arm activities of patients who were diagnosed with lymphedema. So they typically go to lymphedema clinic, for example, to have compression bandages. So we would like to assess if there is an improvement in terms of their level of activities before and after treatment. And finally, this study can also lead to a technological solution for enhanced assessment of functional outcomes after surgery, as well as a platform for novel personalized prehabilitation and rehabilitation strategies. So we are currently collaborating with a group of engineers and a physiotherapist to develop a real-time feedback monitoring, which can guide patient and empower patient to do arm exercises with physiotherapy input. So it can be used to identify patients at risk of developing arm complications, and therefore we can intervene early and possibly reduce their complication rates and therefore improve their quality of life. Thank you so much.
Great. Thank you, Alice, Yasmin, and Amelina, for excellent presentations. And now I would like to open it up if anybody has any questions for all of the speakers or one of the speakers about any of the topics presented.
I have a fairly general question, which may not be one of the things that you have been investigating in your research, but is part of the context and the whole background, and that is the therapeutic side, and whether the effect of this slightly different way of doing things has any effect on the long-term outcomes. That is, if it's going to affect the percentage of ladies who have a recurrence of cancer or not.
So I think that's a really good question, Gareth. Thank you for asking us. I mean, as far as we know, it's as oncologically safe as the other procedures that we mentioned. I think part of the problem in this area, or certainly an area for improvement, is that the evidence that we have could be strengthened. And I think one of the things that I looked at in the big review that I did was the length of the studies in therapeutic mammoplasty. And as I mentioned, the vast majority of them are less than 5 years. So while some of them will be for 10 years or so and provide good evidence, I think that's definitely an area which we could strengthen in terms of safety.
Yeah, could I try and take that a little bit further? I don't know what the statistics are about probability of recurrence after a certain number of years. There is the so-called dormancy problem, that which I don't think is not very well understood, as after perhaps 5, 10, 15 years even, the cancer can recur again in the same place. And I don't know what the statistics are on this as to what are the probabilities of this happening, and what's the rough number of years that you can expect that there will not be any recurrence?
Mhm. So Mr. Leff has kindly hinted, so it's approximately 0.5 to 0.7% per year of recurrence rate for therapy.
0.5% per year, so that's quite low.
Mhm.
Right, okay.
Yeah.
Yeah. And does it gradually fall off, this probability, or is it fairly flat?
It depends a little bit on which type of the biology of the disease you've got, Gareth, I guess.
Yeah.
So, you know, there will be some, okay, this is a very sort of generic statistic, which probably betrays the different biology to a certain degree. But I think the truth of it is we know that the longer you live, the more likely you are to see the disease back in your breast, if you see what I mean.
Yeah.
So it carries on through your lifetime in terms of the local risk of relapse.
Right. But 0.5% a year seems quite low.
It is quite low. It is quite low.
That's good news. Yeah.
Yeah.
Yeah. Does that depend on the type of surgery which is used? If the surgery, for example, is very good at removing all possible cancerous tissue, then you can expect that probability to be very low. But if it's not so good at removing all cancerous tissue, then that's more of a problem. Is that right?
Well, I think probably the best evidence I can give you is the sort of mastectomy versus, you know, breast conserving sort of evidence. And
yeah,
really isn't any evidence that if you were to remove, in inverted commas, all the breast tissue, that's necessarily a better treatment in terms of local relapse than if you did breast conservation. So to take your point to its extreme, you could say, well, I'm going to do a mastectomy then because I've got to get all of the breast. That doesn't actually transpire in the data that, you know, you have a relapse rate, sadly, even if you do a full mastectomy. So I think the point, you know, that Alice is making is, you know, is a good one in terms of the long-term oncological follow-up for things like therapeutic mammoplasty probably still isn't there yet, even though there is data out there. I mean, I think what we do know about it is it does allow us to take bigger volumes of tissue and still spare the breast. So, you know, to a certain degree, there is evidence that our chances of getting a clear margin, if you like, a distance between the edge of the disease and normal healthy breast tissue is obviously that much lower because we've got the scope to take bigger areas of tissue out.
Yeah, and I imagine it depends also at what stage the cancer is at when it's diagnosed. Is that right?
In terms of your long-term, yes, absolutely. In terms of your long-term risk of from an oncologic point of view, yes.
Yeah, okay, thank you.
I have a question for Amelina about the wearables. So my team kindly acted as healthy volunteers to test the wearables, and which they had to wear for 24 or 48 hours. And they found them really heavy, which kind of made them want to take it off. But being good researchers, they pushed through and wore them for the time. Are they developing new wearables that are easier and I guess less of a burden? Because I would imagine if you've had breast surgery and your wearable is heavy, you'd be less likely to want to wear it for a long period of time. Are they developing new technologies in that area?
Sure, thank you, Kelly, that's a good question. Currently with the wearables that we're using, so we're basically getting feedback from the patients when we do the follow-up. We ask them questions about how wearable, you know, the wearability of these wearables, and also if there's anything that we need to do to improve the design and the concept of using wearables. And majority of the patients gave really good feedback, and they think that, you know, it is you know, easy for them to wear them because it's just like wearing a watch essentially on their wrist. But some patients were not compliant towards wearing wearables because they found them a little bit annoying. Sometimes it can be catching on the clothing materials, and it can be a little bit sort of you know, irritating the skin. So we are currently, you know, working with the engineers looking into possibly, you know, changing the design maybe in the future. But at the moment, you know, we are currently using the wearables that's available in the commercially available from Newcastle University. That's where it's been developed. But it's but there are some new wearables in the market, for example, the Apple Watch and also Fitbit, currently being used in different types of patient cohorts of healthy volunteers, but they're mainly they don't have the raw data. What I mean is that so you can't really do your own analysis with it if you use Apple Watch or Fitbit, because all the analysis is done in the software that's been developed by the companies. So if you want to do our own analysis and do finding out the level of activities and do analysis of the raw data, it's difficult. So that's the reason why we chose to use these wearables instead of the other more nicer ones or more wearable, with better design. But we hope that in the future we'll have better wearables so that it will be, better for the patients, and also will increase patient compliance in the future.
Great, thank you. And if I could ask some of the members of the public and patient representatives, how do you feel about wearing things like something that can measure your mobility, or as you know, these devices measure all sorts of things now, of sharing that type of information with healthcare professionals to influence your care? How do you feel about that? Would you be happy to do that if it fed into a system that your clinician could view? Harry says yes.
Yeah, I don't mind.
Yeah.
Although I might start feeling guilty if I don't do much.
I think that's the point of the monitoring or tracking the movement of patients, because then if we have the real-time feedback of the level of activities the patient is doing, then they will be able to see that on their watch and then say, okay, I'm not doing much, so I need to be doing more activities. So it's just giving you the motivation to move more. Right. So I think also that's one of the reasons why we would like to be using wearables, because it's just easy for you to use, and it's like wearing a watch or just giving a nudge if you don't move enough for that day.
Mm-hmm. Michael? You're muted, sorry.
Yeah, oh, sorry about that. Yeah, hi. Just on the tracking device, I did some work for the prison and probation service on tracking devices about 7 or 8 years ago. But is this monitoring movement? Are you hooked into GPS, or are you actually tracking people, or is it just the movement of the body? You must know where they are, presumably, and you can pinpoint them. No,
it's not connected to the GPS. So it is just measuring your level of activities, and the sensors that we have now is not giving a real-time feedback to the patient. So what actually happens is that you wear the sensors on your wrist, and then when we collect the sensors from the patients, then we then connect the sensors to our laptop and then download the data from that. So it's not a real-time feedback for us. But our hope in the future is to be able to do a real-time monitoring to understand your level of activity. So if we can connect the sensors that you're wearing with an app, for example, so the clinician will be able to see what you're doing on that day, or a physiotherapist can see what you're doing on that day. And then if you're not doing enough, or if probably set you up into level of activities A, B, or C, then based on that level of activities, if you're doing very low level of activity, then a physiotherapist might be giving you a call, or might be giving you a nudge, okay, do a little bit more today. So it's just essentially to track and monitor how well you're doing in terms of your level of activities, and then giving you advice on what you can do to try to improve your hand or arm movement. Michael, you're muted.
Sorry, I'll start again. Sorry. Yeah, thank you. I just very quickly, when you move along the activity line, then at some stage it will be 24 hours, or will it switch on, switch off, or is it specifically, you know, from the time you get up, if you're doing exercises in the home and then go out for a brisk run or something like that, it's picking up all this information. If you do it in real time, then it'll be sending back through the app back to the central control. So it will need some kind of location identifier. Am I right?
So I don't think so. I mean, it is something that we'll have to develop together with the engineering department and also with patients as well. So at the moment, we're just doing the baseline study to understand patients' level of activities, and then we'll be able to then do a comparison between different types of treatments. And then once we have that granularity to understand what's going on with those patients, then our next step in the future, once we get further funding, is to then develop this feedback mechanism for personalized rehab program. So at the moment, I'm not too sure, but my understanding is I don't think we need to do GPS tracking, but it is something that we need to look into in collaboration with patients, and also GDPR and all those issues need to be taken into account as well when we do develop the program.
Thank you, Amelina. Thank you very much.
Thanks, Michael.
Gareth?
I had a blood pressure monitor for 2 days continuously a few years ago, and at first it was a little bit awkward, but soon got used to it, and it wasn't too bad. I didn't find it a problem to have it on, so this might be fairly similar. But as a more general thing, which is a little bit off the wall, I'm afraid, there was a TV program about some of the dangers of big data, particularly health data, getting in the hands of very sophisticated AI systems, which can get a tremendous amount of information about individuals. Big Brother is watching you. I think most people wouldn't mind your doctor is watching you, but if it's someone like Big Brother, they might be a bit worried.
Yes, Gareth, thank you so much. That's a good question. So again, this is something that we do need to look into when designing the program. But at the moment, all our data that we collected from patients were all confidential, and we are bound to ethics, research ethics, and everything is just within our research department. But in the future, when we do want to implement the program, it's something that we need to look into, and we are complying, within the law to make sure that we're not giving the data to the third party, for example, and it's just within written health clinicians and also patients.
Okay.
Super. Are there any other questions for our speaker this evening?
I'm sorry, it's Bridget here. I don't think you can guarantee that the system is secure myself, actually. I suppose that's a comment rather than a question.
Okay. Thank you, Bridget.
But I just wondering how would you nudge the person with the wearable? How would you nudge them? Or is it just the presence of the thing nudging them?
Yes. So based on previous studies, on Parkinson's patient or stroke patients, what they did was either using a traffic light system. So, the watch can either give them like an indication, green, yellow, or red. So that will differentiate whether they are, at what level of activities they are in, and then basically telling them to do more or to do less. Or they can use vibration techniques. So the watch just vibrate, just a little bit of vibration, just to let you know what you're doing. It's good enough for that day. So that's the two type of nudges that you can use. So it's something that we need to look into when we are designing the software.
Absolutely. Just this side of an electric shock then.
Not really an electric shock, but it's just a little bit of vibration.
So just this side of it.
Great. Does anyone have any other questions for our panel this evening? No. Well, I would like to thank Amelina, Yasmin, and Alice for joining us this evening and for your very interesting talks, and for everyone else for joining tonight. It's lovely to see you. I haven't seen you for several weeks now, so it's nice to see your faces. And yeah, thank you very much. There will be another Science Cafe in June. Our imaging group are putting together a talk, so I will soon be advertising that. So there will be a Science Cafe in June, and I hope to see you then.
Thank you. Thanks very much. Nice to see you. Nice to see you all.
Thanks very much.
Well,